What we're going to do is we're going to do 5 minutes where they can introduce themselves, introduce their company, and then their thoughts on how medicine is changing with technology. Afterwards, it's going to be an open session. Okay, so we're going to do 20 minutes here between these 4 gentlemen, and then afterwards it's going to be 25 minutes of questions from the audience, things that kind of come into your mind that you'd like to ask this collective group that we have here. Okay, so we're going to go ahead and start with Kevin. You're on the hot seat. Okay, I'll go ahead and give you the microphone, and I'll be sitting right there, and I'll give you guys a warning when your 5 minutes is close to done. You'll see a 2 from me, and then a 1 from me. Okay.
I think they're starting with me because I talk so fast, I'll give everybody else extra room. So, like Don said, my name is Kevin Krauth. I'm sorry, I'm a little sick. I'll hold the microphone, by the way. And I'm the CEO and co-founder of Orderly Health. I'm not a medical physician. I grew up around a family of physicians. My dad is a doctor, and my mom is a nurse, which gave me a lot of perspective on the healthcare industry. So my perspective is going to be more about how I see the healthcare industry changing rather than medicine necessarily. Giving a quick background on Orderly, what we've created is basically a personal assistant, an automated personal assistant to help individuals navigate the healthcare system. You can sort of think of us as like an Amazon Alexa or Google Home for healthcare. And the way that we do that is we integrate multiple different sources of data and services into a text-based interface that you can chat with. And I really should be more specific by saying it's a language-based interface. So we work with companies like Dispatch Health, as well as Hippo. We have a number of different partners, 17 in total right now. And you can use our service to ask questions like, what is the best pediatrician covered under my insurance? Or what is the cheapest price for Lipitor? And we can give you answers right away in real time using these various different services. So the reason that we came about with this idea, or how I came up with this, is as somebody who grew up around healthcare, I've always kind of been fascinated by what I consider to be the inefficiencies in the system. I was supposed to be a doctor, and I let my family down by not following the biz. I ended up majoring in economics and public policy and focused on healthcare policy, but avoided healthcare as an industry like the plague. Because I didn't want to get involved in what I saw was an industry that was hurting from a lot of bureaucracy and inefficiency. So ultimately I went into investment banking and then made my way into tech as a product manager in San Francisco for a software company that served a lot of healthcare companies. And when I went to the doctor, basically I joke that every time I go to the doctor, it's the first time I've been to that doctor, because I've changed jobs a few times and I generally am pretty healthy. So what I saw was the same problems that were sort of trying to be solved without a lot of innovation. I went to what I consider to be like a healthcare country club, if you guys have ever heard of One Medical. And it was basically a concierge service in healthcare that you had to pay extra for. But walking away from that appointment, I still had the same issues of not knowing whether the doctor, not knowing whether the doctor was covered under my plan, not knowing how much things were going to cost, how much was left in my HSA. So I started to explore whether software could help solve this. And the first thing that I noticed was there were dozens, if not hundreds, of companies out there trying to solve small parts of it, but nothing was out there bringing it all together. So that's kind of the impetus for Orderly. And where I see the future of healthcare going is I would really like to see in the next few years to have consumers take more ownership over their healthcare. I think we're still several years away from what I consider to be true consumer-directed healthcare. We're starting to get there with the increase in HSAs and high-deductible plans. But at the same time, I think that consumers are unaware that these resources are there and available for them. So while a lot of employers and insurance companies are moving to high-deductible plans, really this just punishes the consumer because they're left more or less holding the bag after being told for the last 20 years that you don't have to think about it, just go and your insurance will cover it. Well, now they have to think about it, and they don't realize that there is information and there are services available for them. So that's sort of the long and short of what Orderly is trying to solve. We want our business model is based on something similar to Dropbox, where we have a consumer freemium side. So anyone in this room could sign up, and I would encourage you to do it. You can take out your phones and do it right now, I won't judge. But you can go to orderlyhealth.com and you can sign up for our service. There is a free tier, so anyone in the country can use the free version. We have a premium paid tier that's available only in Colorado for specific reasons about the services that we offer here. And then we use that data to sell into the enterprise, where we're selling to insurance companies so that they can use information that we gather on our consumers and cohort and different analysis of how consumers behave, so that we can direct them to the lowest cost, highest convenience, most efficient care. And obviously it's my hope that there are more services out there that are like Orderly to make healthcare more efficient. And I'll pass the mic.
Thanks. Again, my name is Rob Bauer. From my day jobs as a college professor at CU in the Department of Pharmacology. I'm also coordinate the Governor's Consortium for Prescription Drug Abuse Prevention. But I want to talk to you about the third hat, as I'm the co-founder and CEO of a company called RX Assurance based here in Denver that was founded basically five and a half now years ago on the premise that, as you all know, that medications are complicated. Even when you start somebody on a medication, and we manage, most conditions are managed pharmacologically. 73% of all visits end up with a prescription to manage something pharmacologically in primary care. And large fractions of those are in behavioral health and in pain management. You take the two biggest slices, it's behavioral health and pain as almost 2/3 of all the reasons for those primary care visits. And we look at that and see things that you see all the time that end up in your lap in the emergency room, which is people who aren't well managed with medications, whether it's psychiatric or behavioral, or poor pain management, or somebody who's transitioned into a use disorder or an addiction and then ends up drug seeking or having issues with an overdose or a management issue with their addiction, ends up in the emergency department. And that's where it becomes difficult. It's, for you then, it's how are you trying to keep somebody stabilized, but then what do you do about it? Because again, this is emergent. This isn't primary care or long-term management. We've got a lot of holes in doing it. So we saw a lot of opportunity in trying to build solutions to help people manage medications better. We have a whole suite of things we do on the behavioral health side to help docs with prescribing and monitoring patients. And we have patient engagement specialists basically that help patients engage and tell us how they're doing. Basically, they're reporting everything from PHQ-9s and GAD-7s and doing scale-based stuff to watching behavior, and you've seen some of these kinds of technologies, watching people's motion and how they're going, establishing baselines for how people move around. And if they're not following their normal behaviors, we can ping them to see how they're doing and have earlier detection of behavioral health problems like anxiety and major depressive disorder episodes, that we pick those up much earlier. We do all that kind of stuff. On the opioid side, most recently, we've been focusing on trying to address this because of the urgency of the issue. And for example, things that apply to the emergency department setting are have an app-based system to be able to access the state PDMP much more quickly and easily than going out and doing it the crappy way that you've got to do unless you have full integration, which I know you'd like to get. It's very expensive to do because we know who our competition is. But we have a free app that you can basically download, log into. It's called OPSafe Pocket PDMP. Log into that thing, and then if you're on a shift and want to check a PDMP report on somebody, just type in your 4-digit PIN and you're logged in. You stay logged in. You don't have to keep logging in once at a time and logging out or delegating, and be able to check this much more quickly and get the info that you need. And you're also not reading a long PDMP report to see what's going on. You're just getting summaries of that information that you need. And green, yellow, red. It's all green, go ahead. Yellow, take a look. Red, don't prescribe for that person without stopping and looking at something. So building solutions like that to try to help in the ED. We're moving forward to help with solutions on how do you do things like referral into treatment. Very difficult to find treatment resources. And you most often say, gee, we got a list, or maybe social work has a list, or maybe someone has a list of local treatment resources. It's not going to be real-time recurrent. And we're working on that kind of thing, real-time referrals into treatment. So you'd be able to say, for a patient, if they have a readiness point in the ED, how can we get you transitioned into treatment right now? And do that with something simpler. So that's the kind of place we focus on, is in that kind of medication management space. And that's where we see a lot of opportunity, obviously, to do things better. So that long term, we don't have as many consequences. We manage people better. They don't have quite as many visits to you in the emergency department.
I'm Ben Zaniello. As I mentioned, I'm a practicing doc in Seattle, but I spend most of my time as the chief medical officer of a company called Collective Medical, which, how many people have went to the national ASAP, where was it this year? Okay, yeah, okay, maybe I'll ask this question. Who here has heard of Eddie? Okay, that's not bad, okay. We're a small company and our marketing isn't great, so I'm always curious to hear who has heard of us. We are the only software endorsed by National ASAP, and we focus really on the emergency room. And what we do is we essentially create an opportunity for you right before you see a patient to be informed on that patient, to know who their care team is, to know what their past visits are, their past diagnoses. The great point about the prescription drug monitoring database, to create a lookup so that it's automatically done for you, so that you don't have to go somewhere else, that you don't have to log on to this portal that drives us all crazy. And we do that by bringing in other members of the care continuum, partnering with your local HIE, and doing all these things, again, so that the information is in real time, it's accessible, and enables you to focus on the medical necessity of ER care, while today we focus so much on medical uncertainty because you don't necessarily know as much as you'd like to about a patient. It a little bit ties into the other question which we were asked to cover, which is kind of the movement in innovation in medicine. And I, up until recently, was the CMIO of population health at Providence St. Joseph Health, which is a big West Coast-based health system. And what I was really focused on, and I'm acutely interested in, and it's part of the reason I came to this company, is what I feel is a fortunate move in medicine, a very slow move, mind you, away from the very transactional nature of healthcare, which is, and I think almost everybody has touched on it, which is just the very kind of, a patient is in front of me and I'm going to take care of this patient at this moment, and moved much more to a longitudinal care coordination, care management opportunity. And I think we all recognize that that's better care, that when patients are no longer in front of us, they still have medical problems that we are not necessarily caring for, and the opportunity to have a long tail of care is really important. We've obviously all been hampered by this in our practices, by the dreaded EMRs, and I apologize if there's kind of active Epic or Cerner representatives here, but I think that's been one of our biggest issues, is that we codified in all our EMRs all the revenue cycle and billing practices that really forced a transactional billing system. And that's not how people live, and that's not how we want to practice. And I think that's an exciting opportunity, and hopefully, again, this is the slow move of healthcare, with future payment models, we'll be able to push more to better care management and care coordination, and have an opportunity to look at the total care of a patient and follow them after they leave the emergency room and they go to the primary care office or go to the skilled nursing facility, and then leave the skilled nursing facility and go to a different ER. But if we're all sharing data, we have an opportunity for insight into that patient and to make their care better, which I think is exciting. And it's, again, slow going, but I'm an optimist, which is why I took this job. And we're excited actually to start doing this in Colorado and working with you all. So if you haven't heard of Eddie, or you haven't heard of Eddie, please come and talk to me afterwards, because we're just getting started in Colorado and I think it'll be exciting. So thank you.
All right. Last but not least, Kevin Rodelberger with Dispatch Health, the co-founder and chief strategy officer with Dispatch Health. So my background, clinical training as a PA, practice in town here for about 10 years, but was always really frustrated in the way that medicine was delivered, the way that patients were accessing care, as well as how we were all working together, whether it be at the hospital side, payer side, and just in general the community. So I went back to business school here locally at CU to learn really the business aspects of healthcare. Jumped ship from clinical medicine back in 2011 to a local startup here called iTriage, which was founded by a couple local ER docs, Wayne Guerra and Pete Hudson. Really learned the impact of technology and the role it plays in the future of healthcare. Dispatch Health, you can think about us as really technology-enabled, on-demand acute care medicine in the home. So we got our start back in 2013 with a partnership with a local EMS agency, South Metro Fire Rescue, where we were both looking at the opportunity to be able to break down the walls of traditional brick and mortar of healthcare delivery and be able to deliver definitive care in the home. They were looking at their scarce resources on unnecessary transports to the ER. We were looking at market research on more care being performed in the home setting. So we partnered in 2013 to be able to study this really for 18 months to determine, could we deliver effective care through the 911 system and safely, and could we actually provide value to the healthcare system? Meaning, could we impact the total cost of care on these patients and maintain high quality clinical outcomes? And what we found was we made a significant impact on the savings. So saved about $1 million passively, seeing about 400 patients at that time. And started to take this data back to the payers and contract with them directly for the care that we were providing in the home. Fast forward now, today we're operating here in the Denver metro area outside of the 911 system, where we've also built technology for consumers to access us directly through a free mobile app, iOS, Android app, as well as our website. We have integrations with nurse advice lines in the community for individuals to be able to access this for their acute medical needs. We service, again, the Denver metro area, Colorado Springs. We opened that in May of 2017, operated in Phoenix, Arizona, which was opened in August. Richmond, Virginia, opened up in November, and then Las Vegas was our recent market that we launched in December of this past year, and then looking to add another 5 to 8 new markets here in 2018 to be able to replicate exactly what we're doing here locally in Denver. We've seen close to 15,000 patients since 2013 and saved well over $20 million when you take into account the unnecessary care that's being delivered in the emergency department, as well as transports to the emergency departments. If you think about our future, and to your point, it's really about this transition of fee-for-service world to value-based world, and how we can align with the different entities within the healthcare industry, whether it be in the payer community, the health system side of things, and the patients themselves, to be able to right-size care. So how do we provide those access points for patients to be able to guide them, because our health literacy rates in our country are so poor, to be able to give them the appropriate level of care, whether it be through telemedicine, whether it be through on-demand acute care in the home, whether it be home-based primary care, whether it be admitting patients to the home and delivering hospital to home. So there's a lot of ways that we could do a better job at being able to provide them with the right resource at that right time.
Thank you, gentlemen, for making the time to come and talk with us about your respective companies and your vision for what the future of healthcare is going to look like. Let's open it up. Any questions for the audience? Any observations that you want to ask our panelists? Oh, don't be shy now. It's okay. You can raise your hand.
Could you just comment on how you're delivering the in-home care? I always thought Uber was the solution with a medical kit in their trunk, but you probably figured out something else.
Okay, so the question, just because we're recording this for later, is how are you delivering in-home care? And that's going to go to you with dispatch.
Yeah. So I didn't get a chance to talk about that, which is a great question. So I'll tell you just about the care experience, which will lead into our treatment capabilities that we carry in our vehicles. So if you think about those access points that I mentioned, individuals can call us, click on an app, or get on our website to access care. We call that patient back within 5 minutes to be able to go through them to that patient and screen that individual to make sure it's appropriate for us to assign a medical team. Once we go through our clinical algorithms that we built, and it's really a risk stratification tool that we built into our technology, we assign that medical team. That team is an ER trained nurse practitioner or PA, as well as a medic in the vehicle. And then we always have an ER doc on call being able to review those cases as well too. So what we're bringing in the vehicle is not your typical black bag medicine. It's really, this house call on steroids. So if you think about capabilities, Foley catheters, Coude catheters, ability to put feeding tube back in place for those sniff patients, CLIA-certified lab, IV starts, as well as fluids, antiemetics, antibiotics, IV Lasix, IV steroid, being able to suture, staple, 12 leads if need be, net treatments. So a wide range of treatment capabilities to be able to treat those folks safely in the home and definitively keep them out of the ER. And a big portion of our model is maintaining that continuity of care. So after that care delivery, making sure that we're tucking those individuals safely back into their primary care physician to maintain that care.
Okay, any other questions? No? Neil?
For dispatch health, what's the average, number of patient contacts that a care team would encounter in a day?
So it really depends on the different markets that we're in and the size of the markets. But today in Denver, we have 8 vehicles operating in the Denver metro area, which really expands from as north of Longmont, covers Boulder, down to Parker, Castle Rock, and everywhere between. We see typically in a 10-hour shift about 8 to 10 patients in that given day, in that given shift. So just to give you a little breadth of the patient panel of who we really serve, it's about 65 to 70% geriatric population, so working very closely with the assisted living communities, independent living communities, home health agencies, and acting as an extension of their services, primary care groups for access after hours, employers, SNFs, working with them directly as well too, and the health systems as well.
So I'm going to jump in here with a question. Actually, no. After you, I've actually got a question for Orderly.
So this is another dispatch question since we're on the topic. Do you have contracts or some sort of working relationship with any hospice agencies?
I guess the short answer is yes, we did. Yeah.
So for Orderly, so it's going to be myself and then Jim and then Ben. So for Orderly, I think one of the things that we've all noticed in the past few years is these online sites that rank your doctors. Dr. Stater was a douchebag. You should never go to this ER. You should never see him. But that's also influencing and driving different patients to different places. So what are your thoughts about that patient-driven care and those patient perspectives, and how different ERs can kind of either capitalize on that or how that's a risk for them?
Sure. Well, I won't comment on your reviews, Dr. Stater. No, so what we've done, I think it's a good point, and I'm glad you brought it up, because one of the things that we're doing to drive Orderly is actually working with partners that handle various different problems within the healthcare system themselves, so they built an entire business around doing one thing and doing it well. When it comes to ranking doctors and doing reviews, there's not, it's very difficult to build a Yelp for healthcare for reasons you all are well aware, right? Patients are often more concerned about bedside manner than outcomes, and that's a big problem. So what we've done is we partnered with different agencies or different organizations that try to solve this problem themselves, and then we aren't the ones, I always joke we're a little bit like BASF. We don't make a lot of the products you buy, we make a lot of the products you buy better. By stitching together all of this different information from various different services as well as data sources, we can get a better picture of how individuals are interacting with the healthcare system across the board. So unlike an EMR, which can only really look at the claims that are processed, we can actually see what a user is doing before they interact with the healthcare system at all. Because they might ask something like, what should I do for the flu? And then, we can get more intelligent. We use machine learning and artificial intelligence. We can get more intelligent about which doctors we recommend based on the various different specialists, based on the outcomes within a provider network. And one of the reasons that we're starting to partner more and more with insurance companies is that oftentimes the insurance companies have their own internal metrics in terms of which providers, which physicians are the most effective for which conditions and under which circumstances. So that's something that we're trying to constantly improve our algorithm, and we have more or less that the data that we get gives us a really good feedback loop to handle, it's not just you get 4 stars versus you get 3 stars from some uninformed patient.
And instead of running back and forth, why don't we just have you yell out your question and then I can repeat it for our recording.
Okay, I have an Eddie question.
So how many states is Eddie in, and what are the 3 lessons learned from your interactions with different states?
Sure. So today we're live in 13 states, which isn't to say that we blanketed every hospital in them, though most of them we move. It's the network effect, the value increases with the number of nodes, so we try to go for maximal density. So we're live in 13 today. I suspect we'll see another 5 to 10 come online this year. I never take bets on kind of how quickly hospitals move, but my guess is kind of in that number. And from our perspective, the number one way to be innovative in a health system is through you all. And what I mean by that, and I live this as a physician champion within my own system with Eddie, which is how you get projects done, how you get them through privacy and IT and all the roadblocks that exist to innovation, and the EMR, which has sucked all the air out of the room, certainly out of your IT budget and your IT people, is through physician champions. And we, as physicians, we probably wield less power every day, but people still listen when we talk about things we want. And they're particularly surprised and encouraged when it's technology, because generally speaking, we're yelling about technology, not yelling for technology. So if there's kind of a number one thing, and this is how our company has been successful, is very focusing, and it's our relationship with ASAP, is very much focusing on what docs want and having them help us get there, because frankly, we can't do it without local enthusiasm. So that's probably number one. The second piece of it is we're a network company, and therefore just one hospital being in our system is kind of the telephone problem, who they're going to call. So it's important to us to essentially visit communities and get whole regions moving forward and building consensus. But then at the same time, a little bit of the trust fall of that first hospital saying, we think this is the right thing to do, we're going to move forward, and assume that our partners recognizing that once we're sharing our data, they can see data, and we'll all get value out of this together. So that's 2, but those are 2 big ones.
Ben and then Carla.
Question for you. So a significant portion of our population are vulnerable patients, underserved, and then another significant portion are patients with insurance with narrow networks. We have a cadre of folks at the university, I'm sure other hospitals have it as well, who are dedicated to trying to find referrals for these patients, and it's difficult. So how would technology be able to help in that transition?
Thanks. No, it's a great question, and we're approaching it in a couple of ways. One of them is same thing, the network problem, is building enough providers into our networks that are able to refer amongst each other. We have a lot of primary, in Colorado we have about 675 docs using our system. In other states, we're in 43 states, we have about another 500 earlier in those states. But in Colorado, we've been around for about 3 years, 3.5, getting some traction in doing that. And we're starting now with our primary care docs as our largest number, almost 400 primary care docs. Now are starting to access the pain management specialists or addiction docs to say, if I've got somebody with complex chronic pain, this is getting into deep waters for me as a PCP. we're able now to refer and say, all right, there's pain management docs within network to be able to do this. Again, not a payment network, just within our network ability to refer. And then same thing with addiction medicine, where if you're chronic pain, the next problem you're going to see is with chronic pain transitioning to opioid use disorder or another use disorder. And a fraction of patients will have that happen. And same thing, they have addiction med docs who are even fewer in number to make that possible for them to do it. So it's one way we're trying to do that. The second strategy is to build databases where they don't exist, and the federal databases now are not being updated. It was a current administration policy matter in November. And so we had all the SAMHSA treatment locators, everything with OTPs, methadone programs, buprenorphine, any of that is now laying stagnant. So we're working on creating databases of our own with those to know who's available to be able to create those data sets, and the state is interested in that, and to create, it's going to be as good as the data are there, and we want to make real-time availability, not a list, a piece of paper that you've got, like here's the 6 treatment centers in your area. That changes, and it's not a real-time availability kind of data set that you need. Who's got beds? Who can see somebody now that takes Medicaid? And I want to know that now. Where's the closest one to me? And we've built a locator that's in beta. We've got 6 docs participating in the Denver metro area that are receiving patients that way, where you can just simply do a referral from the app, from an emergency department, a PCP, or a patient can put in their own info and say, where's the closest place if I want to get methadone, or if I don't know what form of treatment, they're all different, and be able to feed people and make those referrals and send the info and get the referral done much more quickly. And our third strategy is going to be to work with payers and larger systems once we have some and prove this works, to go to the UC Healths and say, look, and the Denver Healths of the world, this is working. And you've got much larger cadres of physicians than we do to be able to then, again, facilitate referral. We work sort of in that interstitial space where there is, where the systems kind of fall down and we don't know where each other are to try to connect them.
Right. And I'd actually like to add another thing that's unfortunately maybe a little more draconian, and back to kind of effectiveness versus efficacy. And one of the ways you can do this is essentially with technology is using analytics to identify who needs those services most. We deal with this a lot. We work in a lot of rural states where we're live in all the hospitals in New Mexico, and I have discussions with primary care docs and ED docs all in the room saying, our number one need is point of care and actually getting, right sizing and getting people to primary care, but I don't have any primary care docs, or I have 2 in my community and their panels are full. And this is a terrible thing to say, but this is where we are in medicine, is we say, well, we can help you analyze your patient base and say, this is the patient that needs your care resources the most. And it's not ideal, but it certainly allows for a more equitable and a more effective use of the resources you have today, which is unfortunately where I think we often are.
A question for Dispatch Health. You're a proprietary company, and I wonder how you integrate with local EMS. The problem we see in the emergency department is the patient fell, EMS comes out after the patient's family calls 911, they get lip assist, they come in the next day, the hip is fractured, the patient is septic, they have rhabdomyolysis. How do you have integration with local EMS?
Yeah, so we got our start in EMS, and we continue to partner with EMS with South Metro Fire Rescue down south. We are, talking about how do we help align with EMS. There's a lot of work being done in the EMS world across the country relative to mobile integrated health, community paramedicine. There's a lot of different versions of this that are trying to be stood up. A lot of times they obtain a grant to be able to perform some of this, but there's really no sustainability of these models. And what we have found is with our experience on the care delivery and being able to expand those capabilities to be able to partner with those paramedics, and identifying the right protocols when they encounter these patients, that we could show up and be able to definitively treat these individuals in the home. And something that I didn't touch on but is really important in our model is the importance of the home and that surrounding. So, this individual that may be a hamster wheel of, going in and out of the ER, we really don't know what are their impediments to care. Why are they continuing to show up into the ER or into a provider's office? So, it's much different seeing a patient in the home versus seeing a patient in the office setting. So identifying what are those impediments related to fall risk, being able to document, is there food in the fridge? Are they a CHF patient transitioning from the hospital to the home and the only thing they're eating is Doritos? Do they have medications all over the place in their home? And being able to do that medication reconciliation, in the home with them, and identify those gaps and document those gaps in a way that, care managers who are taking care of these patients or primary care physicians has the appropriate data to be able to go further upstream and get them the right resources where we can keep them healthier and let them age in place because we've been able to get this information. It's all relative, to the access to that data.
Well, first of all, that person's sick as crap, they should go to the ER, okay? Next, Kevin had a question for the group, and then anyone else, just so I have my cue correct, anyone else have any other questions? Okay, Steve.
Yes, I wanted to ask a question of the whole panel because it allows me to control the conversation a little bit and prevent it from being a bunch of acronyms that I don't understand. So I think one of the things that we face as a company, and everybody up here is in some way using technology or tech-enabled platforms in order to help with care, is the healthcare space is sort of known for being resistant to technology. I see this with my own dad, like he is always very skeptical. There's this sense of the physician knows best, and any technology that's going to provide patients with information that doesn't come directly from a doctor can undercut the doctor's authority, the credibility, and all that. So I'd love to hear from you all how you guys are either partnering with physicians and providers or overcoming the challenges and the resistance to technology in the space.
It's obviously it is difficult. It's selling to docs is hard. Selling to anybody is hard. But selling to docs that this is showing them value in this, and these technologies have value for them in doing med management or opioid management in our case has value. It's hard to get them on board. Once they do, and I have found that almost any time if I have a few minutes with a doc, 5 minutes, can say these are the reasons why this would be good to give this a try. Have nearly 100% success rate. It's hard to get out there and get in front of them, and to be able to do that is incredibly difficult to do. Once we use the same kinds of approaches that a lot of others do. Channel selling and finding thought leaders and trying to use credible sources to build those networks and build credibility. We're using our software now to lead in terms of helping people do things, but we're also starting with piloting bricks and mortar locations for doing opioid management using our branding, that there are people that are pain management certified and can do things a lot better than primary care or addiction medicine boarded to be able to do MET. And because anyone could do it if you hang out a shingle, but to be able to try to do that and raise standards as far as that in terms of what we're able to offer. It's both technology for any physician who wants to do it, but also then raising standards, showing that if we're doing medication management and we're doing opioid management, we're meeting the Colorado Quad Reg guidelines and CDC guidelines. If we're doing addiction medicine, being ASAM guidelines, and we're showing where we're able to do that and try to set the bar at a high level of credibility.
I'm obviously going to be biased here as a physician, but I guess my take on this is a little bit, and I touched on this before, which is that there's just such bad blood between technology and physicians, and for a very good reason, that there is a psychological thing you have to get past. But I think that has been compounded, and look at us, a bunch of four white dudes sitting on this stage, kind of living this right now, which is that we've been very much trapped from an innovation in a Silicon Valley perspective of this. We're going to go around the medical establishment where all these startups are going to go direct to consumers, and doctors have been as much the problem as a potential solution. And I think that's a really lost opportunity because, again, the EMR has been as bad for patients as it has been for physicians. God, I'm really going after the EMR today. I don't know why, but I think the opportunity there is to recognize that you're really selling to two groups. You may be selling to consumers, but you want to sell to physicians because ultimately the physician's role is if you make a provider's life better, they will make the patient's life better. And I think we've been really struck in our ER practice that we very much focus on making the providers create better care, and therefore indirectly that creates terrific care for patients and makes providers happy. And I think that really resonates. I think as soon as you talk about doctors being in the way or going around them to get to the consumers, you create a channel conflict that I don't think needs to exist.
I'll make it quick, but the benefits of us is that we're a tech-enabled delivery service. So we are building technology for our own staff primarily. We build technology for others, but if you can imagine being in the ER and the next room over are the software developers, and saying, as you're going through this experience, you're giving rapid feedback to those software developers to be able to optimize that user experience for those providers. So we have the benefit to be able to release new features and functionality, whether it be in our robust logistics platform that we've built, to how these individuals are documenting the care on scene, and get that rapid feedback on what's working, what's not, and to optimize that experience. And the better experience that we can provide our providers, the better care that they're going to provide to our patients. So the beauty is having control over that and to be able to solve problems very quickly by having an in-house software development team.
Yeah, and I just want to say for Orly, this is something that we face too, because we're not direct to consumer entirely. Sort of look at the environment being, or the ecosystem being the three Ps: the payer, the patient, and the provider. And for us, one of the biggest challenges has been to try to help you all and help the provider space recognize that in no way is technology going to replace any of the service or the care that you guys give, but rather be an enhancement to it. So our goal, and one of the reasons I wanted to ask you all the strategy around it, is how do we have this an open dialogue, and how do we have the conversation to show that by utilizing things like Dispatch Health and RX Assurance, and I'm not as aware of what you do at any, but by giving consumers some of these tools in tangent with a good provider who is helping administering care, helping them oversee the care that they get and following up, then the technology can become a way to scale yourselves, and you can treat more patients, do it better, be more effective, and then they get better service out of it, they get better outcomes, and that in turn makes them like you more. So, anyway.
Okay, last question of our panel. Sorry, we're 1:30, so maybe we'll last question here.
Sorry, Jim. The question I have for those of you who are based in Colorado, speak a little bit to where you see the health tech innovation community going as time goes on. We've got the Catalyst building that's going on just up the street here with a whole bunch of companies. And those of you who are not based in Colorado, I'd love to hear another company in the health tech innovation space that you're really impressed by. That's not your company or one of the ones that's on the stage.
So the first part was health tech innovation in Colorado. What was the second part? I'm sorry.
Another company that impressed you that's not yours.
Okay, cool. So I moved here from San Francisco in Silicon Valley to start Orderly, and the reason, aside from the mountains and the sunshine and everything else great about Colorado, was largely around what we saw as being the best combination of factors for a startup, and I still insist that it's one of the greatest places. The one missing component that I will argue to my death is that there's not enough VC money here, and especially for early stage in the healthcare space. What you said is true. You got WellTalk, DaVita, Dispatch Health, RX Assurance. There's a ton of startups here. Techstars in Boulder. There's a bunch of other companies here. There's a lot of talent here. I think that For us, I'm very insistent that finding tech talent and keeping it is far easier in a market like Colorado than it is in a place like San Francisco, where it's sort of a per war to keep a single engineer. So that was the reason that we stayed here, and we've been really pleased with our decision. We're headquartered over in Rhino, and we're about 8 people now. I say about because we have some contractors. It's not like half of a person. So as far as other companies that I really admire in the space, there's a lot that I could list. I don't know if there's one in particular in Colorado that I would look at, but I've been really impressed by what's going on at Amino. I don't know if you all are familiar with Amino. Amino has really, they've taken a very Silicon Valley approach to a problem, and I know in a lot of ways that we met with a lot of disgust, because there's nuance in the healthcare industry that maybe isn't present for other companies. It's not just a data problem, but what they've done is basically assembled as much data as they possibly could. It was started by a bunch of former Zillow executives, and they saw it as being the same problem in the sense that you have a lot of different areas of siloed data sets that are being guarded by incumbents who don't want that data to get out there because it then hurts their bottom line. So what they did is they basically spent 2 years and about $20 million hoovering up as much data as they could, and then layering on a number of data science and incredibly smart people to try to organize that data in a really powerful and effective way. And I think that they are finally turning the tide and getting some believers on the provider side, which I'm interested to follow.
Thanks. Yeah, we're excited. That both being here and the growth in the health IT environment here in Colorado has been, especially in the last probably 2.5, 3 years, has been great to see. We're going to be at Catalyst. We've leased our space, and we've been floating around at Industry and Galvanize and other shared spaces, waiting for the appropriate healthcare-related space to pop up for us. So we're excited about that. And we've had some successes with early stage, early funding. The Colorado Health Foundation does impact investment. They have 2 sides. They have a foundation side and an investment side. We have one of the 2. That the other one is as well. That's done educational stuff. So we were able to get some funding that way. We've got OEDIT money from Colorado, which has been good. So grant funding has been there. And now we're getting that we're early revenue, and where we are starting to take up and ramp on our revenue. We're getting the appropriate level of interest that you would think. It's harder here, obviously, than being on the coast, but we're getting enough interest, in Impact Fund and other players like that, where it's the space we're in with the opioid problem is a popular one with impact-related funds, social investment kind of funds now that we're talking to kind of try to grow. But still in my choices for companies that I would talk about, I'd also talk maybe to mention a very small company up in Boulder that does recovery support. And again, a lot of patient engagement stuff we do because our vectors are existing data, like PDMP data from what people are getting with their prescriptions or whatever, or from EHRs. Getting into toxicology and emerging toxicology lab data. We've done a lot on patient engagement, and the value stuff we're going to be doing is doing a lot of patient engagement. And there's a company in Boulder that we're watching. Their name is Gloo, Gloo, and they do this kind of stuff for recovery support and tracking people much more longitudinally to see how recovery looks from people with use disorders. And they're pretty interesting.
I love that you asked a local healthcare technology, one, because it totally puts me on the spot because I'm not from around here, but also because healthcare is so local, and as a company we kind of recognize this, which is that we always kind of partner with local companies as a result. I actually am not going to name a specific company, partially because I want to make a general point, which is I mentioned that we're in 13 states, that we're actively working in at least 10 more. I participate in a lot of the ACEP stuff at the local level at various states, and I think it's a tribute to you all. This is actually the first time there's been a technology innovation thing that I've done with the local ACEP chapter. So I think that's a really good sign for what that's worth.
I think Colorado sucks, and it's bad. No, I mean, I remember back in 2013 when we actually were sitting around a table, probably the size of these tables, Prime Health, and there was probably less than 10 of us, sitting around and talking about this digital health ecosystem, and what could it be? And now there's, Catalyst going on, in our downtown, which I think is, a reflection of what's happening in our community. And there's a lot of exciting things from large companies like the DaVitas of the world down to very small startups, and being able to leverage each other here at a local level to understand how we can collaborate and solve tough problems, and leverage technology as much as possible. I think companies that excite me are other tech-enabled services. I like the delivery of Iora Health, which is really focused on the MA population, like Oscar Health coming out and just on the payer side and being able to disrupt and leverage technology in a way that is going to help engage and have that end-to-end experience with those members. So those are just a couple companies that come top of mind.
Well, I want to thank you, all the panelists, for agreeing to come up and speak with us and share your insights. I apologize that not all of you get rewarded with a cold lunch. but no, thank you, and thank you for what you're doing to help revolutionize and hopefully improve the care of our patients.